So here we'll discuss local regulatory mechanisms of arteriolar smooth muscle contraction that change arteriolar resistance and therefore blood flow. So each individual tissue has the ability to adjust its local vascular resistance and to maintain normal and constant blood flow during changes in arterial pressures. So it's easy to imagine that an increase in arterial pressure would cause a proportionate increase in blood flow through the many different tissues in your body, but that's actually not the case. And the effect of changes in arterial pressure on blood flow is generally a lot less than you might expect. And that's because increased arterial pressure not only increases the force that pushes the blood out through the vessels, but it also activates these control mechanisms that increase vascular resistance to compensate for that increase and reduce the flow. And then on the other hand, when arterial pressure is reduced, vascular resistance is also reduced in most tissues, and so blood flow can be maintained at a relatively constant rate. So it's the parallel arrangement of organs and tissues that allows this regulation of blood flow and the ability for redistribution of blood flow based on local needs. So blood flow can be regulated so that it's flowing through the tissue bed at an appropriate level for the metabolic activity and the metabolic demand of that tissue. So this autoregulation is really just the ability of tissues to keep blood flow proportional to the level of metabolic activity. And the way that autoregulation controls blood flow is by changing the resistance of the vessel. So here's an example of what autoregulation looks like. So on this graph, we're looking at pressure on the x-axis and flow on the y-axis. And in a steel pipe that has no autoregulation and is not able to change its diameter or its resistance, an increase in pressure causes a proportional increase in flow. So there's this linear relationship between pressure and flow. Higher pressure always leads to higher flow in a steel pipe. But this solid line represents a blood vessel that does have this autoregulation mechanism. And you can see that between this certain range in arterial pressure, in this autoregulation range, the increase in flow due to the increase in pressure is attenuated, and we no longer have that linear relationship. And this autoregulation happens because the vascular smooth muscle contracts to increase its resistance over a given pressure range, and this increase in resistance causes a decrease in flow, allowing the blood flow to be maintained at this relatively constant level, even in the face of this increase in pressure. So in this graph, you can see the dramatic effect of autoregulation. So this blue line is immediately after a change in arterial pressure, before autoregulation has had a chance to occur. And then after autoregulation has happened, there's a new steady state, and that's this red line. So remember that blood flow is equal to the perfusion pressure divided by the vascular resistance. So as perfusion pressure falls through this autoregulatory range here to the left, resistance decreases to allow more flow and maintain that constant flow rate. And as perfusion pressure rises through this autoregulatory range here to the right, resistance increases to allow less blood flow and maintain a relatively constant flow rate. So this autoregulation is really useful on both sides. If there's a decrease in perfusion pressure, autoregulation maintains an appropriate blood flow and pressure to keep that tissue alive. And on the other side, if there's an increase in perfusion pressure, autoregulation prevents a waste of blood flow to organs where flow is already sufficient. And there are two main theories that explain this local autoregulation. One is the myogenic hypothesis or myogenic mechanism, which originates in vascular smooth muscle. So it states that vascular smooth muscle actively contracts in response to stretch. The other is this metabolic hypothesis or metabolic mechanism, and it states that there's a link between oxygen supply and demand. So flow and oxygen delivery is matched to the metabolic rate and oxygen consumption. And really, although it's difficult to prove, it's likely that in any given tissue, there's some combination of these two mechanisms that are active. So the myogenic mechanism is the one that involves the vascular smooth muscle cells in some tissues, and that vascular smooth muscle contracts in response to the stretch. So here in this top image, blood vessels that are exposed to an increased intravascular pressure are stretched, and the vascular smooth muscle responds by actively contracting and decreasing the radius of the vessel. That contraction of the vascular smooth muscle increases the resistance to bring the blood flow back down to a constant rate, even in the face of that increased pressure. This mechanism is also important in preventing excessive stretching of blood vessels when blood pressure is increased. There's some evidence that this may be related to the opening of stretch-gated calcium channels on smooth muscle cells. And then, of course, the opposite occurs when the arterial pressure decreases and the vascular smooth muscle surrounding the arteriole relaxes to increase the flow and maintain that relatively constant rate. The second type of autoregulation is the metabolic mechanism, and this metabolic control is used to match blood flow to the local metabolic tissue needs. So it's the presence or absence of metabolic factors that regulate vascular tone. So here we're looking at a skeletal muscle cell, but it could be really most any other tissue type, since most tissue types show good metabolic regulation of flow. And here at rest, the metabolic rate is low and there's not a lot of metabolic factors around. So we have an arteriole supplying blood to this skeletal muscle, and that arteriole has some basal tone and has this radius here. But then in an active skeletal muscle cell during exercise, for example, there's a really high metabolic rate. There's consumption of oxygen, and there's also the accumulation of all of these vasodilator metabolites, including potassium, hydrogen ions, and lactate, carbon dioxide, adenosine, and all of these things lead to an increase in the local osmolarity as well. So the presence of these factors causes vasodilation using mechanisms that are beyond what we'll talk about here, but that vasodilation increases the blood flow. And then we'll reach a new steady state where the oxygen supply can match the oxygen demand of this very metabolically active cell. So tissues really vary depending on which of these metabolites is primarily responsible for vasodilation. But in the coronary circulation, it is most sensitive to adenosine, to carbon dioxide, and to hydrogen ions. And there are also a wide variety of other vasoactive substances that aren't involved in autoregulation, but that alter vascular resistance and therefore alter blood flow and oxygen supply. This just gives examples of a few of them. Many are released by endothelial cells, nitric oxide, prostacyclin, endothelin. So nitric oxide is produced by endothelial cells. It's made from L-arginine by nitric oxide synthase. It acts by activating guanylyl cyclase, leading to the production of this cyclic guanosine monophosphate and the relaxation of the smooth muscle. and nitric oxide is the most potent known vasodilator. Prostacyclin is just also released from the endothelial cells, also causing vasodilation. It's released in response to hypoxia or shear stress, and it acts through this cyclic AMP-dependent mechanism to cause that vasodilation. Endothelin is another factor released by the endothelial cells, and it causes vasoconstriction. And then histamine is released from mast cells in response to trauma. And it's interesting because it simultaneously dilates arterioles and constricts venules, which causes this huge increase in capillary hydrostatic pressure and increases filtration out of the capillaries, causing local edema. And then finally, serotonin is a factor that's released in response to blood vessel damage that causes vasoconstriction in an attempt to reduce blood flow and therefore blood loss.